Yeah. So next talk is on anti-VEGF in DME, the most demanding talk for everyone nowadays. To you, sir. Sir is a well-known surgeon. He don't need any introduction. Sir,
Sure.
please.
Thanks, Anubhav, for those kind words. So, my talk is anti-VEGF in DME. Anti-VEGF in DME is a huge topic, and it requires at least 2-3 hours to talk. So, I'll just try to compress it in 8 minutes. So, these are the various anti-VEGFs in DME. Ranibizumab, innovator. You have the original molecule. You have the biosimilar, aflibercept, Avastin, bevacizumab, Paginax, and now Vabysmo. Now, we'll just come to ranibizumab. And innovator, I'm just saying it's all the same. I'm just combining both together. So why we should give injections, anti-VEGF injections like ranibizumab is they give you improvement in better visual acuity, improvement in vision and reduction in central foveal thickness. That is why we are going to give all these injections. And you have to give these injections continuously, like every month for 3 or 4 months. And after that, whenever the macular edema is increasing or there is worsening of symptoms, you can give injections so that that gain in visual acuity is maintained. So the main point here is we all know that if you give anti-VEGFs, vision is going to stabilize, improve. But why we should keep on giving anti-VEGFs? And patient will ask you, I mean, I'm getting multiple anti-VEGF. When is this going to end? Agreed that vision is okay, but when is this going to end? So the important message here is if you keep on taking anti-VEGFs, in the first year you might need 8 injections, according to the study. And in subsequent years, the number of anti-VEGF injections you require to maintain that visual gain is much less. So in the second year, you might need only 2 injections. In the third year, 1 injection. So this is the importance of, that is the good news. That is the take-home message that you have to transmit to the patient. And the importance is you give 1 injection, macular edema slightly decreases. Now the patient says, sir, maybe I don't, it should not be like that. That loading dose phenomenon, every month 1 injection till maximally you can get the fovea dry, that should be emphasized, and after that you should go in for a PRN dosage. Only if you do that, this kind of result you get. Like in first year you might need more injections, and to maintain it you can reduce the number of injections. So that is the main thing. And when you give injections, what happens? If you see, only around 50% of the patients, they have good improvement, good response to your treatment initially. That is at 4 months or 8 months, at 1 year, they have good response. So only at 50% of the patients, you expect this good response. Now, there are a group of patients called early but inconsistent responders. They improve at 4 months, but they don't improve at 8 months and 1 year. So these two groups, that is 49 plus 43, around 80%, even if you start giving injection in the beginning, you expect a good response. And these are the patients you continue giving injections. Now there are around 25% of patients are non-responders. So even if you give injection, they are not going to respond. And there is something called a slow and variable response, where initially at 4 months you don't get a response, but at 8 months and 1 year you get a response. Okay. So why I'm showing you is how many injections should you give before you say that you're going to switch, or you're going to say patient is not responding. Okay. So ideally 6 injections, many people say, or 3 injections. So the practical take-home message is you give 3 injections. If it is not responding, then it is not responding. You either switch or say that, I've given up. Okay. And if you give 6 injections, what will happen is that 12.5%, that slow and variable response, that also will get included. But for that 12.5%, you don't have to, give another 3 injections. So my practical guide would be 3 injections and look for response. And how do you assess response? It's like, 20% reduction in central foveal thickness, or more than 5-letter improvement in the ETDRS chart. So that is how you assess the response. Yeah, so this is the basis. So if you give 3 injections and it is not responding, then you find that they are not going to respond in the long term. So the lower one, that non-responders, they are not going to respond anyway, even if you continue giving them injections. So 3 injections would be my practical take on this. Then we just talked about ranibizumab. Now we have aflibercept. So why we should give aflibercept in DME? So you have something called as a protocol T, which says that at 1 year, in patients with less visual acuity, if you give aflibercept, the visual gains is much better in comparing to Avastin and ranibizumab. And if you look at the same study at 2 years, there is not much of difference. So now a patient comes with very good visual acuity. It doesn't matter whether you give ranibizumab or aflibercept or Avastin. But if the visual acuity is less, like this, less than 20/50, then aflibercept is going to do better, at least for 1 year. At 2 years, it's going to be all the same. Okay. Now, there is something called in aflibercept loading dose therapy. Like, you every month you give one injection, up to 5 injections. And they find that if you do that, the patient's visual recovery is going to be much better. So, even in this loading dose thing, around 30%, they are not going to respond. And the maintenance, there is always a chance that you can maintain with a normal anti-VEGF. Now, why aflibercept doesn't work in certain patients? See, even in this loading dose technique, around 30% don't work. So there have been studies which show why these aflibercept doesn't work even if you give 5 injections. They say diabetes mellitus more than 15 years, EGFR, estimated GFR less than 80, serum creatinine is more, potassium is more, and then there is an ERM. So when you're giving aflibercept, and when you have these kind of factors, you should always keep it in mind that the response, even if you give monthly injections, 5 injections as loading dose, may not be as good as you expect or as good as has been told in studies. Now, there is something called as a transform DME trial, which has recently come out. They say initially you give loading dose of aflibercept. Now, patient does not have money, but that initial gain has to be maintained. So, this study shows that a biosimilar Razumab, if you give, this gains can be maintained over 1 year. It may not be as good, but it is really comparable. If you can continue the gain using Razumab or a biosimilar, you don't have to keep on giving this intense aflibercept for a long time. Then these are all steroids. We're not talking about steroids, we're talking about anti-VEGF. This has already been mentioned. And now Peginax in DME. Now the main problem with Peginax is, some patients, they may have inflammation. So you always have to be very careful when giving Peginax in DME. I mean, it's not that the drug is bad, but you have to take your call. You have to take all precautions. History of inflammation, recent surgery, autoimmune disease, all these things have to be ruled out before you give Peginax. Because in diabetic macular edema, majority of the patients, the vision is very good. Because it's a disease of the inner retina and not outer retina, so you have to be very careful. Now, Kite and Kessel study shows that Peginax is non-inferior to aflibercept. And the vision can be maintained with a fewer number of injections. Now, what do you mean by fewer number of injections? It means if you are taking aflibercept, you require 9 injections. If you're taking Peginax, you require only 7 injections. So it is not much of a difference, but Peginax is one drug which has got a really good drying effect. So maybe in resistant cases or when you want to make a real switch, this might be of one use. And in studies, Peginax has been given in a loading dose because the study criteria stipulates that. But in real time, maybe once in 3 months Peginax, or because of this good drying effect, even with lesser number of injections, you might be able to maintain the good visual improvement. So that is the importance of Peginax in diabetic macular edema. Now you have a new drug, faricimab or Vabysmo. It's a bispecific antibody, so it acts against angiopoietin 2 receptors also. So what angiopoietin 2 does is it causes vascular instability. So theoretically, there might be a better improvement in DME using Vabysmo, and maybe it has a more long-lasting effect. Probably 4 monthly dosing, 50% of the patients could be maintained. So why this evolution of newer and newer anti-VEGF drugs come is, we want to create a situation where the number of injections you want to give to the patient should become less. From 1 month, it has become 8 weeks in aflibercept. In Peginax, it has become 3 months. Now in Vabysmo, you want it 4 months. Or you want to maybe give 1 injection in a year and maintain vision. So that is why this evolution of anti-VEGF drugs and the need for a new anti-VEGF drug always arises. Now, this is one patient I had DME. He just controlled his sugar, and at 1 month, his macular edema is gone. So this also can happen. And one important thing you must understand is in diabetic macular edema, reduction in central foveal thickness need not translate to improvement in visual acuity. So drying doesn't mean. So the importance of that is, switching should be done at the proper time. So you give an anti-VEGF. Now the edema has become chronic, ellipsoid zone is gone. After that, now you decide, no, now I'm going to give Osidex or some other drug which is going to really dry. And at that point, if the fovea is dry also, the patient visual acuity might not improve. So switching even after 3 injections, it's not improving, you should always plan for a early switch. So that is the importance of central foveal thickness. And why anti-VEGFs fail is because of all these things like drill or wrong diagnosis when you have a large aneurysm or unusual presentations like that. So the basic rule for treatment with anti-VEGF therapy is early switch. You can look for biomarkers and you assess the non-responsiveness. Then this is one patient, chronic edema, gave Paginax and it resolved, but vision did not improve because it was a late switch. And you have to really counsel the patients properly before you give anti-VEGF injections, because whatever points I've mentioned, you should always tell the patient, and you should always tell diabetic retinopathy is an incurable disease and you might need long-term therapy. So my solution would be always go for a loading dose and follow it up with a treat and extend. But treat and extend therapy may not be possible because it might involve initial large financial burden to the patient. At least go for a PRN dose and a strict fixed dose regime. You should always go for an early switch, and no use combining drugs like anti-VEGF and steroids. And always understand, even with your best intensive treatment, 30 to 50% of the patients are not going to respond. And there are other factors which are beyond you, like genetic biomarkers. That patient might not be responding to the drug, tachyphylaxis and tolerance. Now, renal dysfunction and anti-VEGF, it is very important. Because patients with poor renal function, high creatinine, some patients, if you give anti-VEGF, the renal function can become bad. And nephrologists, they strongly believe that if you give anti-VEGF with the poor renal function, they are going to go in for dialysis, and they'll directly tell the patient also, because you got this anti-VEGF, now you have to get dialysis. So just to save yourself, always assess renal function before you give anti-VEGF. Now the patient has gone in for dialysis, then it doesn't matter. Whatever nephrotoxic drug you give, already kidney is gone, no? So it doesn't matter. But these borderline cases, you should always be very careful. Thank you very much.
Thank you, sir. It was such a great enlightening talk. Anti-VEGF is the most important treatment modality we want to know. So one thing I just want to add to sir's talk is anti-VEGF, DME is not like CNVM where you need to give immediate treatment. You can wait for some time, you can get a systemic control, then you can give, even if you are not giving loading dose, you can give PRN doses, see reasonable resolution. You can give injection at few months interval also. See the response, see the vision gain, see the patient compliance. Lot of factors play. Not just anti-VEGF is important, but yes, anti-VEGF is the main treatment nowadays for DME.